rather feel I've been set up, because it's been set out that we are bad, and I have the opportunity now to conduct the witch hunt in the next 10 minutes, and then hand over to Ian, who will tell us how we're all going to make it better. I think my biggest fear of doing this is running over and running just into a 10-minute diatribe of my experience as to why we're so bad. But I hope that I can do a little bit at least to make this constructive. I think the findings of the NC-POD report are entirely consistent with my experience, both as a clinician working in this country and in 3 or 4 other health systems, including the States, where I've got a fair amount of experience doing a trauma and emergency surgery fellowship. What are we trying to achieve doing the emergency general surgical on call? Well, these are the specialties: colorectal, upper GI, HPB, hernia surgery, endocrine transplant, breast may all be on there, and torso trauma. A huge spectrum of disease that at one time or other has been put under the handle of general surgery. But I would contest that if we ask any of our trainees in the audience, and the trainees here or the asset meetings, what they want to be when they grow up, none of them are going to say a general surgeon. They're all going to say they want to be upper GI or colorectal or HPB. They all want to subspecialize at the earliest opportunity. So the challenge to us to deliver care, and why I think one of the reasons perhaps I think we're not as good as we could be, is we're trying to do a broad brush of topics, and we're trying to achieve competence, at least competence in this. The difference is we're not trying to achieve competence in our elective practice. In our elective practice, we're driving to produce excellence. That's the drive, the outcomes we've measured on how well we do. We have MDTs, we have peer review to achieve excellence in our outcomes. And we've seen that by investment of resource, we've improved our cancer outcomes in the specialties that yourselves will work in. But I put it with the broad brush that we're doing at the moment, the broad brush generality of emergency surgery, we're just trying to achieve competence. So what are the factors? What are the factors there that are blocking us to achieve just competence? And certainly those that don't allow us to achieve the outcomes the Americans see. This is something, if we look at the trauma hat on, we've seen in trauma, the Americans' trauma care is far better than most of our organizations, apart from the organization where it's organized properly and effectively and has had time, which is the Royal London. One of the issues is we're trying to develop this model of care. We have moved on from in the majority, from the consultant surgeon delivering elective surgery and emergency surgery at the same time, mostly delivered through his trainees at a 24-hour stint. We have evolved previous ASGBI consensus meetings, moved us in the direction of evolving that. Do we do day-night splits? Do we do 7 days at a time? With the surgeon of the week having continuity of care. What we haven't done is actually come up with really good models that work. We've changed ours in Nottingham on 2 or 3 occasions in the last few years because it's not quite right. Our current version is still not quite right. We have this risk of the onerous rotas. What is an onerous rota? Some of my colleagues, I'm sure, think that 1 in 14 is onerous. But I contend that the days of consultants going in at the weekend to see their elective patients is long since gone. Although it wasn't that long ago when that's what I saw when I was training. Consultants would come in on the weekend, they'd see their patients. But we can see from the reports done, the weekends are when we have the worst outcomes. Not only is it the patient through the day who comes in through the front door, who we have to look after as emergency surgeons, it's the patients on the ward who get ill on the ward. That's a group which we fail to rescue on a regular time. Clearly, in the ASGBI paper that Ian, the questionnaire that Ian did a few months ago, consultants feel that they're delivering more care than ever, direct consultant-delivered care, compared to the trainees. But that still doesn't seem to have improved our outcomes. I do think we've seen a degradation of the on-call team, the team that live to work together and play together. And I think that consistency of approach has got something to do with the issue and the reason why we are where we are now. not only is that team ethos changed, and it's often the consultant who's the only continuity over a period of time, but also the number of people in the team has probably degraded. We have a consistent pull to the elective specialties rather than covering emergency. And the experience of our trainees has also reduced over time. Putting into that the perfect storm is the volume of patients has increased. Locally, we've seen a 10% per annum increase in patients coming through the front door to surgery, and therefore an increase in surgery. And we do have this vexing issue of continuity of care. How do we provide that? Some of us have moved to team working in emergencies, team working in elective, but that's not consistent across. So what happens with your patient when you go away, you take leave, or you don't go in for that over that long weekend, and you leave it to your colleague? Resources. If you look at these, the 5 things, yes, theatres and critical care, and that critical care may well be the reason the American care is better than ours. But all of them are things that we've managed as a specialty or subspecialties to achieve in our elective practice. We have nurse practitioners in the main. We have coordinators of our MDTs and organised MDTs. We have people collecting data for us. But I would contend that I'm not sure I know too many organisations which have the last 3 for their emergency surgery service, despite, as we've heard from Prof McPhee, it's the largest part of the volume of work that we look after. So clearly there's a resource mismatch that's happened. The resource has gone into our elective practices and not into our emergency care. Clearly training is a difficult issue. I think one of the problems that we are where we are is we're not training people correctly. Yes, clearly as consultants we're concerned about that, concerned that the people who are coming off the top of the ladder, we'll need to be more involved with them. We'll need to be involved more at night. The challenge has been EWTD, and that's affected all of us. But we need to look at the way we train people, the breadth and the depth, and what we're actually trying to achieve. Yes, we can put numbers on it, but I contend that, again, we need to be looking at quality. We don't measure quality of training. How many of us really use the 3 o'clock in the morning perforated diverticular disease, and I could have picked it on any general surgical condition, how many of us actually use that as a training opportunity to go through that with our trainees? I would suggest that the majority of people either leave the trainee to it, I don't believe that's training, or come in as Mr. Grumpy, the consultant, which is probably where I am, and do it myself in 10 minutes and leave them to do the stoma. That's not training either, and I'm fully aware of that. So if we're going to train people to do this properly and improve our outcomes, we need to invest in training trainees properly. Looking at the last bit of this slide first, I looked up on Scopus the last day or so about how many papers are written on the emergency workload. I picked biliary colic, diverticulitis, and appendicitis. There are a lot of papers on appendicitis, very little on the other two, relatively on the other 2 topics. They're dwarfed by the volume of academic work that's published on our mainstream cancers. What's more, if you use citation index as a way of looking at how often these used or put into practice or read, very little, under 200 citations for things like all the top paper in appendicitis. It was in the thousands for the cancers. So not only are we not training people, but we're not getting that, delivering the academics, the research into the work stream. I think we've been successful with laparoscopic appendicectomy, but the others, how many of us say we are going to be an expert in managing that care for outside of our subspecialty in things like, if it's colorectal cancer, for stenting as a bridge to surgery, or minimal access necrosectomy for pancreatitis. The breadth now of what we're trying to deliver is too broad. It brings me on to specialization. In a teaching hospital, I work in a teaching hospital, I'm very lucky to work there. I don't think any of us really do general surgery in that teaching hospital. Certainly none of my trainees are trained in general surgery. We no longer do it. I have a fully subspecialized practice, apart from when I'm on call. Then we have this inequality of access. I get into trouble if I do an emergency, if I do an elective colorectal resection. sometimes tempted to do combined liver and bowel resections, but I have to bring a colleague in to do the bowel bit. But I can do what I want in the middle of the night. That's inequality for patients. If the care seems to be better in the daytime to find an elective case, why should that be different at night? It brings up what I call the on-call lottery, the subspecialty on-call lottery. I don't think we can all put our hands on the heart and say we manage the different aspects of care the same as our colleague. I don't manage inflammatory bowel disease as well as and the complexity of that, as well as my colorectal colleagues. Or even perianal sepsis, and ACP are pushing it to be very specialised. I leave that to my most junior trainee. A lot of people would think that was wrong. So I think we're also providing on-call lottery. Who's on call? Which specialty? If it's outside their specialty, then they probably get what that consultant, either what the trainee does or what that consultant learned when he was a trainee. Because we don't deliver, we don't embed the changes, the research into our practice. Just a few things, say, to bring on, I think, to Ian's going to say, how are we going to get this better? I think we have to talk about value. We have to talk about delivering value. It's the new term in management. If we're going to fight for our emergency patients for resources, changing our service delivery, it fits different organisations, understanding that different organisations have different needs, if we're going to improve quality and our patient outcomes. So this is what I think that we should be aiming for. If we're aiming for excellence in elective practice, we should not sit here and be happy with just competence for our emergency patients. Leave you with this. I wanted to bring out one of the elephants in the room. I don't own an elephant, but I do own a pig. So hopefully I brought a few things into the front, and I look forward to Ian answering our questions.